Hi guys, my name is Chhavi Mittal. You know me as an actor, a content creator, an author, among other things. And a lot of you would remember me as somebody who battled breast cancer very recently. But today I'm here to welcome you to Treat to Beat, which is a part of our larger initiative, Sanjeevani United Against Cancer. You know, at the time that I was diagnosed with breast cancer, I had absolutely no idea what this disease is all about, no matter what I thought in my head. But during the course of my treatment, there is a lot that I learned, and I was able to bust a lot of myths surrounding this disease. Naturally, this cause is very close to my heart, the cause of creating awareness, telling women what to expect, and how to make this as comfortable as possible. And today I'm really fortunate to be having a conversation with one of the leading medical professionals in this field in the country. We'll have an absolutely unbiased and informative chat about cancer with a deep dive into breast cancer. I'm talking about Dr. Sewanti Limaye, Director of Medical and Precision Oncology at Sir H.N. Reliance Foundation Hospital. Dr. Limaye has served as the consultant of medical oncology at the Dana-Farber Cancer Institute in Harvard Medical School and at Columbia University Medical Center, USA. She's the co-chair of the Asia Pacific Coalition Against Lung Cancer, the co-founder of ILON Precision Oncology and Impact India International. Welcome, Doctor.
Thank you. Thank you, Chhavi.
Really looking forward to having this chat with you.
Very nice of you to have me here, and also to Sanjeevani United Against Cancer that has put this together, and really feel fortunate to be here on this seat, being able to be a voice against cancer and come together to raise this mission.
Doctor, my first question to you is, why did you choose the field of oncology amongst everything?
Yeah, this is it's one of my favorite questions, and I like to talk about it because it was very unexpected. I come from a family of doctors. All my family members are mostly cardiologists.
Okay.
So I was supposed to be a doctor, supposed to be a cardiologist. I married one, for sure. But this is mainly when I went to NYU to do my residency. In the final month of my internship, I went to do an elective, and I was sent to Sloan Kettering Cancer Center because we had a partnership with Sloan, and that's where we would rotate as interns as an elective. And when I went there, I was actually quite stunned with the way cancer patients were handling. Most of the cancer patients were handling this news, information, reality of a challenge against death. And I saw them fight without a baggage. I saw them fight the fight of their lives. And it's something that was transformative to this young self that I was. I had just reached US. I was a small town girl. And the year end of my internship was spent at Sloan Kettering Cancer Center. And I realized I was going on with my baggage. But here people were who were faced against death and dying. And they were fighting this with the spirit that I had never witnessed so up close and personal. So I often say this, I went into oncology not because of the science of oncology, although I practice science, but because of the spirit of oncology. It's the spirit that I saw amongst the patients that actually made me discover my passion.
I think all these stories are so inspiring. I think, and I totally relate to you when you say that we all keep thinking about our own struggles, and here are these people who are fighting the battles of their lives with full gusto, without any complaints, and just striving to survive. So, Doctor, I have a very layman question for you here. What exactly is oncology? I mean, if somebody suspects that they have cancer and they want to get themselves tested, no matter what cancer it is, do they always go to any oncologist, or is there like a specific specialty oncologist for different cancers?
So in general, there is a surgical oncology team, medical oncology team, radiation oncology team. These are the three major divisions. But the reality is also that 60 to 75% of cancers are discovered in advanced stages. So mostly when there is advanced stage and cancer cannot be cut out or cancer cannot be treated for cure, cancer can still be treated to prolong life. And such patients then come to us where I practice medical oncology and a special kind of medical oncology. So medical oncology plus precision oncology is what I practice. But the difference between a medical precision oncologist and a surgical oncologist is a surgical oncologist will do the surgery and take it out. To answer your question, when in doubt, get to an oncologist, whether it be surgical oncologist, radiation oncologist, medical oncologist. It's not going to be a waste. The fastest you can get to a leading person who can help triage your case, understand what this is made of, and tell you, who you need to go to. I say gatekeepers. There are certain, and some of the oncologists who've had a track record, who've been there, done that, then emerge as gatekeepers. Patients many times will go to a hospital but also ask for a oncologist, and that may be a surgical oncologist or a medical oncologist, mainly to then get triaged appropriate.
Okay. So in my case, I had gone to a surgical oncologist I got the surgery done first. Right. So I also want to ask you, doctor, that you've been in the field for so long. There was a time back in the day when cancer was not so common. And I remember that when somebody was diagnosed with cancer, the only question people would usually ask doctors is, how much time do I have left? Right? But now there's a lot of advancement in the field of cancer. The deaths have reduced a lot, but why have the numbers increased so much? Why is there so much incidence of cancer around us?
So again, that's also a very good question. I think when you look at how things are in India in general is undergoing something called epidemiological transition. Now,
what is that?
I had to read around it to understand what it exactly means, because everywhere I went, 8 years ago, I came back from the US, and I have since then tried to understand the differences in presentation between the West and India. And what I realized was we are a young nation. We are going through a lot of evolution in healthcare. So we are seeing a lot of deaths from infectious disease going down, because our doctors are doing a better job at saving lives from infection. Earlier, we would have much higher mortality from infections in pediatric population, in youngsters, in our elderly. So now we are seeing a lot of control on that. But by the same token, we are also seeing a lot of chronic diseases increasing in numbers, because people are living longer, people are surviving more from the infectious diseases that we would perish earlier. We've all heard of smallpox, plague, and all those things, HIV taking lives, TB, tuberculosis. And now all of those are getting managed better. So we have more population becoming of age. And when we see that, we see a lot of diabetes, a lot of hypertension, a lot of chronic diseases lingering, and so are the cancers. So that's one reason. And this concept of epidemiological transition is true for all chronic diseases. So it's not just cancer. And so we are seeing this increasing number of cancers because we are living longer to then experience cancer at a later age. As we say, cancer is a disease of aging. Genes mutate as we age, parts get older, and then this concept of cancer where autonomous proliferation of cells happens.
Whenever I talk about my cancer on social media, a lot of people start leaving comments that, oh, you have to stop using microwaves, stop using your phone, stop using non-stickware, stop using, so many things, plastic, anything that comes out of a plastic packet. How bad are these things in terms of increasing cancer?
So a lot of the work that has been done is able to pinpoint on this or that and tell us that these are not directly linked to malignancy.
Right.
But I can also say by the same token that significant amount of carcinogens are undiscovered yet. 20% of cancers are hereditary.
Oh, okay.
And 80% are bad luck.
And talking about breast cancer, doctor, there was a time, again, back in the day when we only saw older women get breast cancer. And even today we hear that you have to have healthy pregnancies and breastfeed your babies, and chances of you getting breast cancer reduces, have babies on time, things like that. But why do we see so many young girls get detected with breast cancer?
So there has been an urbanization of India. I would say the factors that were not predominant in rural India are now actually transforming in evolution. A lot of our women are now living in the cities. Even in rural India, there's a significant amount of urbanization. By that I mean people marrying late, people, especially women, engaging in careers and not having a pregnancy that early on as India was used to having. So we see a definite shift. So we saw a lot of sedentary habits which contribute to hormonal imbalances. But now we are also seeing the in thing amongst the urban India, where we talk about vegan food, or we talk about exercising, we talk about fitness, and you yourself are an example, an inspiration truly, where we can draw inspiration from you with regards to fitness. But we still lack significant amount of awareness. As urbanization of rural India happens, we will see less work being done with our own hands, more sedentary habits, and more use of fatty food that contributes to weight gain. And weight gain is linked with diabetes and with cancer, and also utilization of alcohol. And any amount of alcohol is now flagged by American Cancer Society as carcinogenic, but definitely more than 4 drinks has been there as a rule for breast cancer for time immemorial. So all of that is shifting in our societies, and we see more number of younger women coming in with breast cancer, but also our genes. I feel that we have a significant amount of triple negative breast cancer, which may be genetically driven in India, and that's a different makeup of our breast cancer patients in India biologically.
Talking about comparing India to overseas, since you worked so much abroad as well, how many women, what is the statistics of women getting diagnosed early in the US or abroad vis-a-vis India? And what about the treatment options which are available in India vis-a-vis abroad?
So I'll answer the second question first. So ballpark, I would say treatment options for breast cancer are very, very up to par with the West when we come to India. And when we look at early stage breast cancer, the treatment options that are offered in early stage breast cancer today, standard of care, guideline wise, is quite similar to what we have in the West and what we have in India. The problem is with making it into early stage. And when we come to advanced stage breast cancer, and I'm talking stage 4, non-curable, something that cannot be cut out, cannot be radiated, is there to be treated and suppressed. Many good things have happened with even advanced stage breast cancer. So today, if there is someone who has hormone positive breast cancer, still advanced stage breast cancer that has spread to other organs, but is hormone positive, we can give a targeted therapy pill and a hormone pill, and that woman may be able to respond to such a combination treatment for years. And then we have the next type of oral targeted therapy pill and hormone pill, which can then go for another year or 2 years. So chemotherapy doesn't even start until much later. So really, a lot of the scenario has changed even for advanced stage breast cancer. There are targeted therapy options for women who have target receptors, and they actually can live for years on IV intravenous targeted therapy.
What exactly is targeted therapy?
Breast cancer cells or any cancer cells on their surface could have multiple targets. These are called biomarkers. I
Okay.
call them flags.
Okay.
You know, so breast cancer cell has at least 3 flags. It has ER, PR, and HER2/neu.
Right.
So any woman who has breast cancer must ask these questions. Am I hormone positive, which is ER, PR positive? Or am I HER2 positive, which is the third receptor, third flag? Or am I triple positive? Or am I triple negative?
Okay.
So these are the most basic classification of breast cancer.
Okay.
And then there is this, when we talk about other biomarkers in breast cancer, there are many, many genes that can be mutated. And they can be discovered with additional testing called next generation sequencing. These are genomic analysis with which we understand the specific biomarkers of breast cancer, and especially in advanced stage cancers, you need to figure that out for better outcomes. So when you are marking the treatment to target that particular receptor,
Okay.
it's called targeted therapy.
Okay.
And we have immunotherapy working in breast cancer for triple negative breast cancer patients. So today,
What exactly is immunotherapy?
immunotherapy, so when I said targets, these are targets on the cancer cell.
Yeah.
These are on the surface of the cancer cell. There is an entire modality of treatment that is available to the world today. It's called immunotherapy. It works through body's own immune system.
And what about the early detection you were talking about vis-a-vis the West?
We have very minimal ammunitions or program methods like screening
Yeah.
to detect our breast cancers early. We as a nation, in general, don't screen, right? We don't screen. So in our families, and I'm talking about my family, right? In my family, if I look around, in my colleagues' family, if I look around and if I ask, have their parents, have their cousins been screening? Have you screened last year? Have you screened 5 years ago? Are you going to screen this year? Are you going to screen next year? We only go to the doctor when we are in a problem.
When we start seeing the symptoms.
When we start seeing the symptoms, whether it is common cold or a breast lump or a neck lump or an ulcer in the mouth, we actually don't go just for a well visit.
Right.
The concept of a well woman visit is non-existent, and I'm exaggerating, so please take it with a pinch of salt,
course.
but I just want to drive home the message that we as a nation, we just don't have any plans in place for the general masses to screen.
I'd like to add a personal experience over
Yes,
here.
please.
I was hosting a conference where I was talking to a breast cancer surgeon, creating awareness about breast cancer and how screening is important and how self-examination is important. And yet, I took in so much knowledge, but yet, as a layman, I thought this is not something that can happen to me, so I don't need to get myself tested. And 15 days later, I was diagnosed with breast cancer,
Oh
which
my
was
God.
only by accident. It's
Right.
not that I actually took the effort to go, and God was kind, but it's not like that with most people, right?
I would second that and add a fact. So Globocan data from 2023, 1 in 2 men and 1 in 3 women would be touched by cancer in their lifetime.
Any kind
They-
of cancer.
Any kind of cancer.
Right.
And this is last checked in 2023. Earlier, I used to present this as my first slide of my talk. And I thought maybe this data would have gotten better. And so in 2023, this is the fact released by Globocan. So cancer is an epidemic, and it's a global epidemic. We have to really understand, internalize this fact, and figure out methodologies as a nation to screen. Because what is more cost effective? If 60% of our population is going to get diagnosed with non-curable disease, as morbid as cancer, we are going to pour all our resources into treating stage 4 disease. I once met someone who said, this was a person with a modest living, who said, we wish that if something has to happen to one of our community members, we wish that is a traumatic accident and not cancer, because we don't have the money to fund the treatment for cancer. But think about how much money we will save if we are actually funding for screening
Yeah, correct.
instead of therapy.
Correct.
The number of scans, the number of blood tests, the number of genomic analysis, the cost for the drug, the cost for admission, the morbidity, infections, pain control, all of that comes with advanced stage cancer. So I think we all need to really come up in the arms and stand up to understand and move the needle to incorporate screening and early detection in our routine health checkup screenings. And of course, routine health checkup is also a challenge. We in India don't do routine health checkups. So really, the horizon has to shift. If that is one message that I can really put forward in our chat today, it is an integral message that I would want to leave, that we have to really think differently now and shift our numbers of early detections and how different we are from the West. And the West is only different because they screen.
Absolutely. And what are the early symptoms to look out for in breast cancer?
So how do we pick up the early symptoms?
Yeah.
So self-examination, self-breast examination is one of the easiest ways to pick up something. And we say right after the period, after the menstrual
Why
period.
is that?
Because pre-menstruation, the breast tissue is engorged.
Okay.
So there are certain hormonal changes. That engorgement may make you miss a breast lump, a small breast lump. But self-examination with the palm of the hand for a woman who's having a shower or a bath, when undressed, post-menstrual period, so that the breast engorgement is already gone, and a good self-examination of the breast and also of the axilla.
What is axilla?
Just the underarms.
Okay.
Is very critical, because that will give you the first red flag. So that's the first test that women should do on a monthly basis. It's one of the most basic interventions that we can follow to prevent a large mass from appearing in anyone's life. And then, of course, there is clinical breast examination. So clinical breast examinations with your gynecologist is also something
How
which
often
is very,
should they
very,
be done?
So I say in younger women who are less than 40, who don't have any significant family histories, a once a year examination is good enough. But as we age, and if someone comes into an age group where breast cancers become common, above 50, above 60, those times more frequent clinical breast examination may be warranted, but at least once a year one should advocate once a year examination. Then comes more professional interventions, which mainly I'm talking about ultrasound and mammograms. So breast ultrasounds in younger women, we call sonomammo of both the breasts, and mammograms. And so if you look at the US task force and the recommendations with regards to mammograms, anyone who's 50 and over, yearly mammograms should be done. Anyone who has a family history even can start at the age of 40.
Okay.
And so these are preventative mechanisms, but I think the most basic is to be self-aware.
Right.
We say at our institution, we say be breast aware. So as simple as doing breast self-examination is also most critical, and visiting your gynecologist once a year, and in addition to the breast examination with the gynecologist, a pap smear once a year to prevent cervix cancer also is in the package. So at least these two malignancies, which are highly preventable, should be followed and screened.
And self-examination should only be done once a month, which is not so much to ask. A lot of people feel that mammograms are very painful and I don't want to get it done. Your thoughts on that?
So I have had mammograms. I think it's all in the mindset. So, and tender breasts can definitely be experiencing more pain. So again, for women who are still premenstrual and who have more frequent breast tenderness and pain, should consider doing the mammogram post their menstruation.
Okay.
When the breast is less sensitive. Take a paracetamol before going if you're that averse to doing the mammogram.
Okay.
And then if someone is that sensitive, or if someone has such sensitivity issues, see, we can all have different thresholds, but there can also be real discomfort. So if someone is really having a significant difficulty doing the mammogram, then I would think consider a breast MRI.
Okay.
Which is a much, it's not an invasive method at all.
Right.
It's more labor intensive because you have to lie in the MRI machine for a certain period of time, and not every center that has an MRI will be equipped to investigate the breasts because it's a more nuanced and more recent test. But a breast MRI is something for a person who may be very sensitive to mammogram. So
and
that's
also
the
talking
message.
about statistics, I mean, understanding that if a mammogram is important for me to save my life later, I mean, that also helps us once we know the statistics. So what are the statistics which tell us how many patients are diagnosed in the early stages and how many of them are diagnosed in the later stages in India vis-a-vis the West?
So a large percentage of patients for other malignancies get diagnosed. When we talk about all malignancies, 60% of all cancers globally are diagnosed in late stages.
Okay.
But when we look at India, I would say 75% of all cancers get diagnosed in late stage, advanced stage. And only 20 to 25% are able to be caught early.
Are you talking about all kinds
All
of cancers?
malignancies.
Okay.
But when we talk about breast cancer, thankfully, the advanced stage of breast cancer and the percentage that gets diagnosed with advanced stage is still lesser. But the locally advanced breast cancer numbers are much higher. Even in India, we see the maximum percentage. Around 50% of our cancers get diagnosed in a locally advanced stage.
What is locally advanced stage?
So locally advanced is a large breast primary, multiple lymph nodes in the armpit, the axilla, and the lymph nodes in the middle of the chest can get involved. The lymph nodes in our above our clavicle, collarbone, can also be found to be positive. So the entire area gets affected if there is a local spread of the disease. And so a huge percentage of our Indian breast cancers are diagnosed in locally advanced stage, which would be somewhere around stage 3. And so stage 3 numbers are really the heaviest burden of disease of breast cancer in India. And that is because women are feeling the lump, but hesitant to seek help, hesitant to go to a doctor. And the lump continues to grow. Breast cancers, a very limited percentage, we say almost around 15% to 20% of breast cancer will be de novo metastatic, like initial presentation with stage 4 disease, so aggressive that it will just be frowned to have presented with a spread. Such type of breast cancers are actually small percentage. We talk about small percentage of such cancers presenting. So you get enough warning. With breast cancer, you get enough warning. You have the breast lump, it's on the outside, it's an organ that can be felt by the person themselves, by the woman themselves. And you see that growing over a period of time. And the biggest reason why we then find it in locally advanced stage, when it has already gone to the lymph nodes, when the journey of the cancer cell has left the tumor and gone to the lymph nodes and the other stations, is because we delay in seeking help. And I think it becomes extremely important to outline this point here, that when it becomes locally advanced, we have to utilize everything: surgery, chemotherapy, radiation, everything is on the cards, which may not be the case when we have a very small lump. We may not need everything.
Yes, absolutely. I think my cancer was diagnosed in stage 1. It was a grade 1 cancer. We completely avoided chemotherapy, and a surgery and radiotherapy did it for me. And I'm absolutely fine now. And all that is because it was detected early. So if you feel a lump, please don't hesitate to show it. In all probability, it'll be nothing, but what if it is? And then the next question which patients feel is that, oh, if I undergo chemotherapy, if I undergo the treatment, I'll lose my hair, my skin will look bad, and what are the side effects that I'll face? Do you get patients like that?
So all the time. And I think some of their concerns and fears are true.
Yeah.
They are real. But some of them have now been tackled. So earlier, one of the biggest fears used to be the nausea. When we
Okay.
give chemotherapy, it can cause significant nausea, but now we have excellent drugs that prevents this degree of nausea. Patients are able to go through the treatment without any significant issues with vomiting. Some patients still have issues with nausea and vomiting, but largely we have controlled that. In terms of the hair loss, we have the scalp coolant. So there is a cap called the dinghy cap.
Okay.
It cools the scalp to an extent where the perfusion to the scalp goes down significantly. It's not a complete winner. It's not that 100% of hair loss can be prevented, but 50% of hair loss can be prevented by wearing the dinghy caps.
And what about once the hair loss happens? Does it come back?
Of course. Again, a very common question with patients. Once we finish the chemotherapy cycles, it takes 3 weeks for the early hair to start coming back.
Okay.
The fuzz comes back. But 3 months, most of my patients then walk in looking anew and with a new hairstyle and with a new bob and looking very, very cute and pretty. And I've always said this, I'm inspired by my patients.
Oh, it's in fact a second birth for them. So
It's a new normal.
Yeah.
And a lot of the patients, and I say this, human mind is very tenacious. As the treatment begins, very, very soon, patients come to terms with what is happening to them. They then figure out strategies to empower themselves to become smarter than the issues that they are having with the treatment. And by the time they are undergoing the second or the third treatment, they're actually counseling the next patient and the next
person who's
breast
going in.
cancer presentation.
Actually,
it's so amazing.
I'll tell you another fear that I had in my mind, and I think a lot of women will relate to this, is the organ itself. Mastectomy. I mean, a lot of women feel that breast cancer is equal to mastectomy. Yani ki, you get breast cancer, you lose your breast. Is that true?
Not always. And that's where we have to detect the cancer early.
Right.
So when the tumors are small, it is easy to perform breast conservation surgery. So many, many years ago, trials were done head to head to compare the survival amongst women who were having organ loss, which is radical mastectomy,
Right.
versus breast conservation surgery. So those who had breast conservation had to then sterilize the area with the help of radiation.
Right.
So either you did mastectomy or you did breast conservation surgery and radiation, and the survivals were the same.
Oh.
So there is nothing that you lose if you do breast conservation with radiation. You just need to then complement it with radiation instead of having to lose the organ.
Okay.
Now, when we have bigger tumors,
Okay.
you can't do a conservation surgery because it's such a big tumor. There's a 6 centimeter, 9 centimeter mass in the breast. You just don't have enough breast tissue around it
To conserve.
to conserve.
Right.
In such situations, there is a concept now of, so first of all, we shouldn't let the breast mass get that big. That's the
Right.
message on the wall,
Right.
right? So we have to self-palpate, clinical breast exam, get to the right doctor, get diagnosed early so that this is still early stage cancer. The treatment then becomes very simple, much simpler treatment, early, emerging out of the treatment as a survivor and as someone who has won over the disease, and you move on with your life.
Yeah.
When we have larger tumors, we have to do everything mostly, and that's where conserving the breast may become a challenge. So in women where we still wish to conserve the breast, a woman who has a larger tumor, we then give neoadjuvant treatment. What does
Okay.
that mean? Neoadjuvant means before the surgery gets done. And you give
Okay.
chemotherapy, or you give chemotherapy and targeted therapy, or you give chemotherapy and immunotherapy with different kinds of breast cancers. Different treatments are advocated. And that helps shrink the tumor.
Okay.
Many, many times the tumor disappears. We call it complete pathologic response. And in that setting, breast conservation is still possible.
One of the biggest fears that I also had when I asked my doctor, and I've asked my doctor 50,000 questions before I actually went in for the treatment, is that how would the quality of my life would be after cancer? because I'm somebody who's physically very active. Would I be able to do all those things that I love doing with my body after cancer, or will I be living like a sick person for the rest of my life? So after discussions, we decided to set treatment goals for me. And I mean, I felt that the goals that I'm setting for myself are very difficult to achieve. And I'm very happy to say that I was able to achieve them without really putting a time limit to it, just taking one step at a time, still 70% away from my goals. But as in your medical opinion, I want to ask you, how practical is it for a patient to set these kind of goals for themselves?
So, first of all, congratulations to you, Chhavi. And that's one reason I say I'm inspired by our patients,
Right.
the patients around us. Because even a breast with such a diagnosis, to ask the right questions, to find the solutions, to indulge in it full-fledged, to understand how can I get the best treatment and still how can I come back to full form.
Yeah.
Ask all the quality of life questions, ask all the recovery questions, be ready, be charged to fight this in every which way, physically, mentally, emotionally. That is half the battle won. And of course, also a huge appreciation for your doctor, because someone who sits the patient down, who has these conversations and shares what they know over the decades and years of their experience in that moment that we share with our patients. We then impart the knowledge that we have gained with experience on to the patient. So that's like almost a classroom where you're giving this information, imparting this very critical piece of knowledge to the patient to empower them. But quality of life is something that is to a large extent recovered completely if the person has early stage cancer. That is why it is very critical to wage a war against cancer with screening, because that's where we will catch it early. We will catch it when there's least morbidity to the patient. That is when we'll be able to return the patient after the battle in a normal way.
Yeah.
Instead of having to go through an organ loss, instead of having to go through major scars on their psychology, and instead of having to battle advanced cancer where cure is not promised. So quality of life is saved, salvaged to a large extent. Many patients who are able to really bring it all together, work through their treatment. A lot others work right after their treatment.
Okay.
Even the women who are not working women are still contributing in a huge way as mothers, as wives, as daughters in their families, and they are able to go back to being their own selves in their families. And I think that is a huge battle won in cancer treatment. When we are battling advanced breast cancer, even then the drugs today are really transformative. And actually for hormone positive breast cancer, a woman diagnosed with advanced hormone positive breast cancer, like I mentioned earlier, the treatment is hormones, which are pills, and targeted therapies, which are also pills. I would say above 80 to 85% of women who have hormone plus targeted therapy pill actually are leading normal lives. They're not feeling anything. They are with minimal side effects from the therapy themselves. So they are able to go back to their routines as early as a month after starting therapy, and a month that too not from the treatment but from the disease itself. The disease may be doing certain things. Let's say there's pain in the bone or some shortness of breath or something else that the woman may be really facing. It is almost within a month or a month and a half that the person could come to a certain state of normalcy, and the quality of life can immediately enhance and improve from where they were diagnosed. They could totally be living normal lives. The hair could come back, their exercise tolerance would be back, they could be going to the gym. One of my advanced cancer patients very recently, and every year there's a new sport that she engages in, and I'm so inspired. She sent me, I haven't done bungee jumping, but she sent me pictures of paragliding and bungee jumping and scuba diving, and that's why truly inspired by how really the challenge is undertaken, and that is of course empowered by the quality of life recovery that happens on chronic treatment. So people who are on immunotherapy, targeted therapy, the treatments have become much, much simpler, and in essence, it then is able to preserve quality of life, and in some cases actually enhance quality of life, because you start concentrating on diet and exercise, on your body, on your mental health, on your emotional health, so much more than prior to diagnosis. You start focusing, your family starts focusing, and so it is something, it's a life-changing event.
Absolutely. Like for me, it was instantly prioritizing myself and my happiness and my health, which I'd never thought about earlier. You always end up taking your life for granted.
So I would say in terms of quality of life, there is such a resurrection of quality of life that could happen even with advanced disease. So there is so much hope, even if diagnosed with advanced cancer, there is so much hope. Seek that hope, seek care, seek the right treatment, so that best treatment, least quality of life compromise, and longest life and best outcome is achieved.
Yes, absolutely. You're absolutely right when you say that. And I wouldn't deny that there are some low moments that one feels, and the scars on the psychology that you talk about. I mean, those are the scars which others cannot see, but you can always feel them. But I always like to say that those are the scars which make me who I am, and I wear them with a lot of pride. Doctor, you deal with cancer patients day in and day out. Can I ask you a personal question?
Yes, please.
Do you ever feel scared that what if you get it someday?
All the time.
So what do you do for it?
All the time. And it's actually comical that especially oncologists, if we get a certain symptom, the first thing we think of is nothing cancer. Benign. We always think cancer, because that's what we battle day in and day out. Right. So I stay, I'm actually responsible. I stay up on my screenings.
Okay.
And I'm also a part of research intervention where we are looking at blood biopsy predicting cancers in early stages.
Wow.
And so as a researcher, because I do this with such passion, that I have also been the guinea pig and tested my own blood multiple times as a research subject. But I know that those tests are really on the horizon, and they will help inform early diagnosis. They'll help empower early diagnostic strategies very, very soon.
Okay. So you know that if, God forbid, anything happens, you can completely be under control.
One wishes to be under control. But what will happen, we never know.
Yeah.
So what can be the under control thing is preventative strategies.
Right.
So doing the right thing, avoiding the carcinogens are the most critical.
Yeah.
And that's where I say if there is a known carcinogen that you're aware of,
right,
you have to think of avoiding. And since we are talking about breast cancer, a cancer that is leading in women, the other cancers that are also coming through in women are lung cancer rates are rising in women because of smoking that is going up in women. So, carcinogens that can be avoided, early diagnostic methods that can be put in place, at least we have to be responsible enough to do them and not be shy. And especially if someone has a history of breast cancer, ovarian cancer in their family, or any kind of cancers in their family, please go screen.
Now I have some rapid fire true and false questions for you. Men are immune to breast cancer?
No, men are not immune to breast cancer. Certain types of breast cancer can happen in men.
Wearing underwire bras can cause breast cancer?
So no specific evidence to that.
Breast implants raise the risk of breast cancer?
So again, no specific evidence to that.
Using deodorants can cause breast cancer?
No.
Advanced breast cancer diagnosis means I may die soon?
there are a lot of treatment options that have come through, and even women with advanced breast cancers are living more number of years than they were earlier. So it all depends on what biomarker. So always ask the question, which type of breast cancer
Right.
does that patient have? What are the biomarkers? These are questions that we ask in precision oncology. Biomarker identification or target identification is most critical. Personalizing therapy to that patient is also a norm now. There is no cookie cutter bucket treatment happening. This has to be understood, which type of breast cancer, which stage, what is the biology, how much of the risk to come back. All those questions need to be asked, and that's where this comes in from.
But all things said, the word cancer still instills so much fear in the listener's mind and heart. And I cannot help but recollect how my doctor broke the news to me the first time. I got a call from him, and it was not the name that I wanted to see flash on my phone screen just after I've done a biopsy. So I wasn't very happy to receive that call, and I picked it up. And he did not use the C word throughout the conversation. And I asked him later, why did you not use the word? I kept asking him, doctor, do I have cancer? He said, Chhavi, just come in. We'll talk about it. We'll discuss your options. And I said, doctor, do I have cancer? I kept asking it. He kept not telling me. Eventually, he just said, yes, just come in and we'll discuss it. So when I asked him, he said that patients get really scared and you don't know how they'll react. So I don't want to break that news on the phone to them. I want to first tell them that you're in good hands and everything is good and this is how it looks, and then tell them that this is it. So doctor, can you tell us 3 things which will help take away that fear from people's mind about cancer?
So first of all, recognizing that your doctor was very nuanced. Very nuanced in not really, these are the finer things, not yelling into the phone the diagnosis, being very sensitive to the fact that the patient can be in a vulnerable situation, and the sensitivity of it may trump everything else, and how you would react and what kind of mindset you would have on the other side, where there may be no one to assist you. So these are the finer things that we need to be cognizant of when we are really approaching these kind of diagnoses. But when we talk about cancer, cancer has always been equated with death.
Yeah.
Right? So cancer equals to death. And that has really been ingrained into our societies for time immemorial. But the newer generation now is beginning to understand that there are very high cure rates, especially for early stage cancers, especially for breast cancer. I mean, the cure rate itself would be above 95% for a low grade stage 1 cancer that you mentioned, that you have won over. And so cancer is also cure. Cancer is now also quality of life. Cancer is also courage. So people talk about being at battlefield, and then there are others who actually challenge this phenomenon and say, I don't want to make my disease sound like a battle. Why do we equate this to a battlefield? Because it is a tough treatment. It is something that requires tremendous amount of courage to face the diagnosis, to take the challenge, and to say, I am going to get rid of it. And I'm going to fight my level best. I'm going to give in all the energy, all my concentration to go through the journey so that I emerge victorious.
Yeah.
So a lot of times I feel I'm a coach and encouraging the patient, because that's what you need to do. To a large extent, cancer, from cancer diagnosis to completion of treatment, it is a mind game. It is how you prepare your mind and how your coach, which is your doctor, prepares your mind to help make your journey simpler, seamless, smoother, so that the treatment can be delivered in the best possible way for highest cure rates.
Okay, that was very, very well said. And it just sounded so positive and inspiring to hear something like that from a professional like you. Doctor, would you like to say something as a last message to the women who are currently battling breast cancer? My
one message is of a a very internal, very emotional message to all women who are battling breast cancer is my head is bowed. My head is bowed in appreciation of the realization that a battle fought is a battle won. One of my professors in the US always used to say, when you have a patient who you can cure, you are with a bigger strategy. But even when you cannot cure, you still treat the patient. You are still with the patient. So I am forever with my patients. I am signed on to that. But really, my head is bowed in appreciation to the battle itself and to the inner strength that every woman who's fighting this battle has to win, and the determination, the conviction to emerge on the other side victorious. So all the more power to such women, to you, Chhavi, to have won this and be on the other side, and may you be the inspiration that you all you are to millions of women across.
Thank you so much.
And also I want to comment one last thing. Thank you for really sharing your journey. I think more women should come out and share their journey and be a motivation to the others, to those who are fearful, to those who are not as empowered as you are. So really, congratulations.
Thank you so much, Doctor, for all those kind words that you used for me, and also for sharing so much information with us. And to my audience, I want to leave you today on the thought that there are many diseases which are not curable, many diseases that we choose to live with, but breast cancer doesn't have to be one of them. It is so easy to just get yourself screened and just get yourself detected early. In all probability, you're not the person that 1 in 3 women that we're talking about, but in case you are, help is here, and all you need to do is get screened on time. And the reason why I have shared my entire journey with everybody is because when I was diagnosed, I was very ignorant. I had so many myths about breast cancer. I was scared and I was directionless, and I felt that it is important for me to share my journey so that women can understand what is it that you should expect, and the outcome doesn't have to be so sad and morose. So I'm going to leave you on that, and for more such content, follow us on our social handles and check out our microsite. Thank you so much.